My name is Brian Taylor. This is week 3 assignment of MFT 6102 for North Central University. In this assignment, I chose to view the movie A Beautiful Mind. In this movie, the main character, John Nash, fits the DSM-5 criteria for schizophrenia. This diagnosis is given by the meeting of 2 or more of the 5 symptoms. In John's case, the delusions were present and severe, hallucinations were present and severe, negative symptoms were present and moderate, disorganized speech was not present, and abnormal psychomotor behaviors were not present. At the time of John's admission into the hospital, he is experiencing severe paranoia and delusions. His negative symptoms include attempting to hide his delusions from his colleagues as well as his wife, difficulty interacting in public, such as when he was giving a lecture to one of his classes, and recurring obsessive periods of work, which caused him to miss other engagements and appointments. John has been experiencing these symptoms for a number of years. While manic work episodes have occurred during symptomatic times, these are functions of Nash's delusions, thereby ruling out schizoaffective disorder. Nash's symptoms are not the result of any physiological effect, such as illicit drug use or medical conditions. Nash's schizophrenia appears to be combined with a potential diagnosis of autism spectrum disorder. At any rate, he meets the diagnostic criteria for co-occurring due to the hallucinations. When he was seeing Charles, he was seeing Parcher, and he was seeing Marcy, and the delusions, paranoid and grandiose behavior. Some of the associated features of Nash's schizophrenia are anxiety brought on by the delusions and the disruption of his sleep-wake cycle. Nash works at all hours, and the resulting lack of sleep will likely amplify many of the cognitive and emotional effects of the hallucinations and delusions. Nash is unlikely to become violent against others, but he has had an episode of self-harm and violence against property. For instance, when he threw his desk, out the window. Also, prior to his hospitalization, John seems to be unaware that his hallucinations are real and that he is delusional. His tics may be an associated feature as well. Due to the severity and long-term history of Nash's hallucinations and delusions, many other disorders can be ruled out from a differential diagnostic standpoint. Major depressive disorder, bipolar disorder, schizoaffective disorder, obsessive compulsive disorder, and post-traumatic stress disorder can all be excluded. Based on observed behaviors, it's likely that Nash at one point would have been diagnosed with Asperger's syndrome. The ICD describes Asperger's syndrome as a disorder characterized by the same type of qualitative abnormalities of reciprocal social interaction that typify autism, together with a restricted, stereotyped, repetitive repertoire of interests and activities. It differs from autism primarily in the fact that there is no general delay or retardation in language or other cognitive development. This disorder is often associated with marked clumsiness. There is a strong tendency for the abnormalities to persist into adolescence or even into adult life. Psychotic episodes occasionally occur in every early adult life. However, Asperger's syndrome has been removed from the DSM-5 in lieu of placement on the autism spectrum. While some of Nash's behaviors and social interactions would indicate a diagnosis of very high-functioning autism spectrum disorder, once again, the delusions and hallucinations indicate a co-occurring diagnosis. Nash's narcissistic tendencies are likely amplified by his autism, which is the inability or difficulty to relate to others, as well as his schizophrenia, which is the inability to trust others due to paranoid delusions. As a therapist, I would expect his narcissistic attitudes to reduce while addressing the more severe and pressing diagnoses. Another important point to make is that schizophrenia is much more common than one might expect. I just wanted to give a brief description of the schizophrenia disorder, which I got from two scholarly articles that I was able to look at. One article being the biology of schizophrenia. The second article was Schizophrenia, a Beautiful Fact. The lifetime prevalence of the disorder is approximately 1%, meaning schizophrenia is twice as prevalent as Alzheimer's, even though Alzheimer's is more widely known and much more understood by society, and just as prevalent as autism. It also ranks as one of the top 10 causes of disabilities in developed countries worldwide. Yet what really separates schizophrenia from other mental disorders is that rather than the cloudiness, confusion, and other debilitating diseases like Alzheimer's, schizophrenics experience hyper-awareness, over-acuity, and an uncanny wakefulness. Furthermore, for reasons yet to be determined, the onset of the disorder is slightly earlier in males, usually at the age of 20 to 26, than it is in females, which is ages 26 through 32. However, a paradox lies in the fact that schizophrenia affects both males and females equally as profoundly, and occurs worldwide across all countries, cultures, and cross-sections of society. Moreover, schizophrenia has no known cause and no known cure, although its symptoms are considered manageable with proper treatment and pharmaceutical therapy. But as we examine popular representations of schizophrenia more closely, we will continue to see that the manageability of this disorder is certainly up for debate. Although schizophrenia is so misunderstood in society, even movies try to do their best to give us an idea of what it's really like. In the movie that I viewed for this assignment, A Beautiful Mind, John Nash's schizophrenia is foreshadowed and reflected through Ron Howard's clever camera work. Before Nash's schizophrenia is even revealed in the movie, the camera is constantly moving around, even in scenes where no movement is necessarily called for. The camera often circles around Nash and around the scene, taking on his perspective, just as his mind is constantly moving. It is almost as if Nash cannot sit still. It's like his mind cannot stop thinking, and neither can the camera quit moving. Nash's moving thoughts are nicely paralleled by the substitution of the transient moving shots in place of the traditional still frame. The same is true for the music as well in this movie. It is always moving up and down. It is beautiful music, just like the mind of John Nash was considered very beautiful. But there is no rhyme nor reason. There's no method to its movement. In fact, even the first scene of the film is a fantastic example of both how the elements of the camera and the elements of the music try to recreate the schizophrenic effect. In Nash's case, the first hallucinations occurs as he is beginning his postgraduate studies. While the disease often includes cognitive decline, this does not appear to be the case for Nash. While the DSM-5 indicates that treatment is effective and a small number of people may recover completely, it is typically expected that a patient would require ongoing support to avoid or deal with episodes of possible remission. There's a variety of risk factors for this diagnosis. The DSM-5 lists reasons of birth, minority populations, the developing in urban environments as potential markers. Also, a history of mental illness or psychosis within the family can be expected. But these are not a guarantee of the diagnosis. When evaluating a patient, social and cultural norms should also be investigated to see if delusions are part of some type of culturally expected response. From a gender standpoint, women typically have a later onset of symptoms and are more affect-laden with more psychotic features. None of these potential diagnostic features are presented with Mr. Nash. Nash should be monitored, however, for suicidal attempts, as suicide is often common with this disorder. But Nash has a very limited history of self-harm. Functionally, Nash is suffering greatly in his relationship with colleagues and with his wife. And his work is suffering due to his delusions. Schizophrenia has a very devastating impact on all members of the family. For example, family members usually need to cope with their caregiving responsibilities, their own emotional distress, the symptoms of schizophrenia, increased stress and disruption, as well as the social stigma that comes along with this diagnosis. As caregivers, families share three essential needs: for information about schizophrenia and the mental health system, for skills to cope with the disorder and its consequence for their family, and for support for themselves. Each family has unique concerns and needs. No family handles schizophrenia in the same way, which are likely to change throughout time. Even within a given family, the needs of individual members differ, from parents to spouses, siblings, and offspring of people with schizophrenia. Communities also differ. Some communities may offer excellent services for schizophrenia, while other communities offer maybe very few opportunities to deal with this diagnosis. As far as a treatment plan for Mr. Nash, one of the first things that I wanted to make sure of is to encourage the medication adherence, while also being sensitive to his history of medication. I chose to use cognitive behavioral therapy to deal with Mr. Nash. This type of therapy would deal with three main things: teaching skills training, reframing hallucinations and delusions, as well as identifying triggers. Family behavior therapy will also be utilized to educate the family and create an environment of lower stress. Cognitive behavioral therapy has been known to be the most efficient type of psychotherapy when treating a psychological problem. Cognitive therapy is a therapy that teaches people new, more adaptive ways of thinking and acting. Based on the assumption that thoughts intervene between events and our emotional reaction, also behavior therapy is combined with the cognitive therapy, and therefore should help the patient perform more effectively in life by reducing the symptoms and focusing on the important aspects of life. The treatment that was demonstrated in the movie had a very different approach. Mr. Nash was put into a psychiatric hospital and he received antipsychotic medication. Also, towards the middle of the film, he was administered insulin shock therapy. CBT, I chose to use CBT to focus in specifically on the delusions themselves. Some of the main objectives will be to maintain a rapport and a sound therapeutic relationship with Mr. Nash, to facilitate Mr. Nash in understanding how his beliefs and thoughts influence his feelings, as well as his ability to cope. I want to explore the evidence for and against the delusional beliefs that Mr. Nash is experiencing. My goal was also to facilitate Mr. Nash in designing and carrying out reality testing experiments to gather information about delusional beliefs. Last but not least, I want to help Mr. Nash generate alternative explanations and thoughts that can be helpful, healthy, and balanced. Two specific interventions that I chose to use from this model is, number one, identifying situations that are often avoided and gradually approaching, these feared situations. Number two, I want Mr. Nash to keep track of his feelings. I want him to keep track of his thoughts and the behaviors, and be aware of the symptoms. And this way it will make it easier to restructure these thoughts and to restructure the behaviors. The family therapy that this treatment is based on will also help identify expectations of the family members and how these expectations affect their interaction with Mr. Nash. Additionally, connections will be made between the family expectations and their emotional response to what Mr. Nash is experiencing. Appropriate expectations will be explored, and problem-solving sessions will allow family members to meet their emotional needs. Family members will also need stress management training to help deal with some of the issues that they're going to be going through as well. And they will need to learn what their limits are so that they can realize when they reach their limits and figure out different things that they can do once they do reach these limits. This was a very interesting assignment. I really enjoyed watching this movie. I learned a lot from it. In my line of work, I deal with a lot of schizophrenic diagnoses. I have several people on my own caseload that is diagnosed, with schizophrenia. So I deal with it a lot. But this movie and this assignment gave me the opportunity to look at schizophrenia from a different perspective. It gave me an opportunity to kind of see it firsthand and what somebody goes through with it. But even more than that, watch somebody who is very high functioning as far as their cognitive development, somebody who's very intelligent, how they deal with it. A lot of times when I'm looking at people who's dealing with it, I'm looking at people who are also dealing with substance abuse problems, who are dealing with other co-occurring disorders. So this gave me a little bit of a different perspective. Again, I really enjoyed it. I learned a lot from it. Watching the movie, looking at some of the different scholarly articles, gave me a totally different perspective. So I do think that I have a better understanding, of schizophrenia, and it will help me as I move through the marriage and family therapy field, and it will also help me even now as I go back into my job and work each day with people who are diagnosed with schizophrenia. So once again, I enjoyed doing this. I really appreciate this opportunity and look forward to the remainder of this class. Thanks a lot.